Alrighty, so welcome to Road to 250, our special Valentine's Day edition. So we'll be talking about some cardiac anatomy and the cardiac action potential. So we're going to start with some cardiac anatomy. So yeah, our heart is located in the middle mediastinum between the vertebrae levels T5 to T8 and slightly askew to the left. Usually, sometimes you can see people with a slight skew to the right, but in most cases it's to the left. Put that there so we know what side we're talking about. So the heart itself has 4 chambers, 2 atria, 2 ventricles. Who knew? The ventricles and the atria are separated from each other by atrioventricular valves, and they are present in something called an atrioventricular septum, which can be visible on the outside of the heart as the coronary sulcus, which is this area right here. Same thing on the other side. And then in between the 2 ventricles, there is an interventricular septum, and this is visible on the surface of the heart as the longitudinal sulcus, either the anterior one that we see here or the posterior one on the back. And then between the 2 atria, which we can't really see, but pretending that it's somewhere there, is the interatrial septum. And an important thing to know about that is that it's going to be thinner than the interventricular septum, because this guy is going to be more important for the contractile force of the ventricles. So it's got to do some more work there. And the heart has 4 valves. Whoa. We have the atrioventricular valves that we were just talking about up here. On the right side, we have our tricuspid valve, which is named because it has 3 cusps, which you can't really see, but pretend there's a third one here. And on the left side, we have our bicuspid, named because there's only 2 cusps. It's also known as our mitral valve. And these guys have attachment to papillary muscles, holding these cusps in place. And our other 2 valves are our semilunar valves. On the right side, we have the pulmonary valve. On the left side, we have the aortic valve. And in addition to their different shape, what's unique about these guys is that they don't have attachment to papillary muscles that we saw here. So that's a little something special to know. And taking a little page out of first aid here, just so different view of the heart from above here. The most posterior part of the heart is the left atrium, as we can see. And a interesting pathological clue here is if this atrium gets enlarged, it can cause dysphagia or hoarseness, either by compressing the esophagus back here or compressing the left recurrent laryngeal nerve, which shows up in a lot of questions. So good to know about that guy. And on the next slide, I'm going to go more into depth about the pericardium and its layers, as well as the other layers of the heart too. I'll talk about those. And just keep in mind, from here, the pericardium is innervated by the phrenic nerve. And so if you have inflammation of the pericardium, it can cause referred pain to the shoulder because of that. Okay, so a little more about the structure of the heart. We're going to talk about the heart wall, which has the endocardium, myocardium, and the epicardium, and the pericardium. So the endocardium, which is this very thin layer that we see here, is made up of simple squamous epithelium. And it's important to know that this is continuous with the endothelium lining of vessels. Your arteries and your veins are all continuous with this tissue. And your myocardium, which is your big old bulk of your heart here, is composed of involuntary striated muscle with collagen in between there. And important to also know that the myocardium is arranged in this swirling pattern. You can see here, kind of makes a little figure 8 around the atria and ventricles. So it's just kind of what it looks like. Of the myocardium, the majority of the cells here, about 99%, are muscle cells. And these are contractile cells that are connected by intercalated discs. And this helps with a rapid response, as well as allowing for something called syncytium, which basically means that all of the cells can contract together as one with a single action potential. And the remaining little bit of cells are our pacemaker cells, and they're important for conduction. These guys are much smaller than the muscle cells we talked about here, and have a few myofibrils in them as well for very limited contractibility to make the heart contraction a little more efficient. And we have our epicardium covering all of that, which got really weird. And lastly, we have this pericardium on the outside. My descriptions are going to vary a little differently than what this picture looks like, but I'll hopefully explain it a little clearer for you. So on the outer surface of the pericardium is our fibrous membrane. And on the inside is a double inner membrane called the serous membrane. So, which is this blue layer here that I'm horribly outlining, but this serous membrane houses the pericardial cavity, which inside all of this slightly darker blue area is where pericardial fluid is produced, and this provides lubrication for the heart. And then as far as attachment of this pericardium to the remaining surfaces between the serous layer and the fibrous pericardium, we have a parietal pericardium, so that's our parietal layer there. And then between the serous layer to attaching to the rest of the heart, we have what we call visceral layer. Are we good so far?
Yep.
So now we're going to do a little quick overview about the coronary vasculature. So from the aorta, we have two main branches. We have the right coronary artery and the left main coronary artery. The right coronary artery branches down to a number of other branches, but the one we're going to talk about most is the right marginal artery. And this supplies the right ventricle. On the left side, we have it being branched off into the left anterior descending artery, which supplies the interventricular septum here, 2/3 of the anterior side of it, as well as the anterolateral papillary muscles and the anterior surface of the left ventricle. And then we also have the left circumflex coronary artery, from which you also see the left marginal artery supplying the lateral side here towards the apex. But the left circumflex goes around the heart on the left side to supply the lateral and posterior walls of the left ventricle, as well as the anterolateral papillary muscles. Something of note here is our posterior descending artery, or also known as our posterior interventricular artery. So we're talking about interventricular septum back there, which supplies also the AV node partly, the posterior third of the interventricular septum, and the posterior 2/3 walls of the ventricle, so the back wall there, and the posterior-medial papillary muscles. So in the majority of people, there is a right dominant circulation where this artery, the PDA, arises from the right coronary artery. So it goes down. In about 8% of people, we see a left dominant circulation where the PDA actually arises from the left circumflex instead. And in an even fewer amount of people, we see a codominant circulation where it arises from an anastomosis of both the right coronary artery and the left circumflex artery. And some other things of note here is that the right coronary artery is extra special because it also supplies the SA and AV nodes. So if you have an infarction here, you're going to have some nodal dysfunction that can present as bradycardia or heart block. And our left anterior descending artery also has a little special note here, as it is the artery that is most commonly occluded. And one last thing on this slide is coronary blood flow peaks in early diastole. So while the heart is filling with blood to get ready to pump out to the rest of the body, but hasn't done it yet, it's gonna supply itself the most during that time. Cool? And I'm gonna just run through this one more time in a different sort of visual, just to make sure we really have that honed in there. So from the aorta, on our right side, we have a right coronary artery, which, remember, supplies our SA node and our AV node as well. Part of it stems into the right marginal artery, supplying our ventricles, and can contribute posteriorly to the PDA. And this image is clearly showing a right dominant circulation. And on the left side, we have our left coronary artery, which from it can branch the left anterior descending artery, as well as the circumflex artery, which will branch off into the left marginal artery, as well as go around towards the posterior portion of the left ventricle. And in the fewer amount of people that have left dominant circulation, the PDA will be stemming from the circumflex artery here. And for those with codominant circulation, our PDA is going to be stemming from both, the right coronary as well as the left circumflex. So any questions about any of that before we move on to the physiology portion? Alrighty, so we're going to talk about some action potential physiology, some basic principles. We have different cells within the heart, as we talked about. We have our muscle cells and our pacemaker cells, and they're specialized for different functional roles, and some of them overlap. In general, these are going to be for the automaticity of the heart, conduction, and contraction. So starting with automaticity, cells here are initiate action potentials spontaneously. They do it by themselves. And these cells are coupled via gap junctions. So when one of the cells fires an action potential, it'll sweep throughout the heart. So this was that syncytium that we talked about a little earlier. The three types of cells that we care about the most here are SA nodal cells, our AV nodal cells, and somewhat of Purkinje cells. Not as much, but still kind of there. So our SA nodal cells are especially important here. These spontaneously depolarize to the threshold, and they have the highest intrinsic rhythm at about 100 per minute. And because of that, they are known as the pacemakers in the heart. Then we have our AV nodal cells, which have the second highest intrinsic rhythm, about 40 to 60. And these can become the pacemaker if the SA nodal cells become damaged. So if the highest one is damaged, it'll go down to the second highest. And lastly, we have our Purkinje cells, which aren't really technically specialized for automaticity, but they do still have spontaneous depolarizations, which make them count at about 35 per minute. Let me change this to color we can more easily see. So when we're talking about cells for conduction, the ones we want to pay particular attention to are AV nodal cells and Purkinje cells. AV nodal cells are specialized for slow conduction, and they do this by having a small diameter, few gap junctions, and because of this, their depolarization rate is 0 is going to be slower compared to fast conducting tissues. We can compare it to the SA node. And the Purkinje cells are specialized for rapid conduction. And they do this by having a large diameter and having many gap junctions, so their phase 0 is going to be rapid. And they're part of the His Purkinje system, in case the name wasn't clear enough as it is. But The reason we have this difference for slow conduction and rapid conduction is our AV node wants to make sure we have pause, something slowed down, so our ventricles have enough time to fill up. All that blood in there. The reason we have a rapid conduction in our Purkinje cells is because we want to get that blood all out at once as fast as possible. So we want to make sure all of these cells are activated quickly and together to get that blood flowing out. And lastly, when we talk about contraction, we're talking about our myocytes having spontaneous depolarization, and they're conducting electrical impulses between each of them, as you see here, there's electrical current going on. And these guys contain the protein machinery in order to contract. So by that, I am referring to the structure within the cell. I'm talking about actin, myosin, all of that allows it to contract as well as relax again with each action potential. Make sense so far? Okay. So just to quickly go through the flow of our cardiac conduction, we begin in our SA node. We're starting there, which is going to conduct through our atria and reach our AV node, conduct our atria, which has, like we mentioned before, a slightly slower conduction rate to allow time for the ventricle to fill up, which then conducts through Purkinje fibers, right down here. So going down the left and right bundle branches that we see here to our Purkinje fibers and to the ventricle to allow it to contract. And one more time, the SA node is our pacemaker, and our AV node has our delay. Remember, our nodes receive their blood supply from the right coronary artery, like I mentioned before. And note here for our pacemaker rates, again, the SA node is the fastest, the AV node is the second fastest, and Purkinje and everything else comes last. As far as speed of conduction, our AV node is going to be the slowest because we want that pause to allow for filling, and our Purkinje cells are going to be the fastest so we can have that rapid synchronized contraction. Okay, so the next few slides I'm going to be using a variety of images, so don't get too scared about it. I will go through them, just giving you a little heads up so you have it here. So before we move on, does anyone have any questions about what we just talked about?
You're good.
Okay. We're going to start talking about the resting membrane potential in non-nodal cells. What are non-nodal cells? So when I talk about non-nodal cells, I am referring to our ventricular or atrial myocytes. So when they are at rest, potassium conductance is high. So this is your cell at rest. You're going to have this potassium conductance going on continuously. It is just there. It's doing its thing. It's pumping potassium out of the cell. And this also occurs in Purkinje cells, so important to note there. And the resting membrane potential is fairly close to the potassium equilibrium potential, which is -95. So it doesn't take too much to start an action potential because of that. And also note that this high potassium conductance also occurs because there are two major types of channels. There's this particularly ungated potassium channel that's always going to be open and always pumping out potassium, and it's going to be maintained unless we reach the equilibrium potential, and then this doesn't have as much of a high conductance. Their conductance is going to go down. And we also have our inward rectifying potassium channels, and these are voltage gated channels that are going to be open at rest and closed during depolarization, and then they open again when the membrane repolarizes. So I've included an image of some voltage gated potassium channels. These aren't exactly the ones that I'm talking about here, but just use them as a visual for now as our rectifying inward potassium channels that allow for this loop to continue so you can keep pumping out potassium. Okay. Now we're going to talk about the actual action potential that goes on in these myocytes. There are slight differences in the action potentials between the atrial myocytes, the ventricular myocytes, and the Purkinje cells, but a little too in depth right now, so I'm not going to go over that. Don't worry about it. And again, remember, cardiac cells are electrically coupled by gap junctions, which allow for when a cell fires an action potential to spread to neighboring cells. And again, there we have our gap junctions that allow us to do that. And yeah, so in the next few slides, we're going to go through this action potential for our non-nodal cells. We're going through phases 0 through 4 and following along with our fun little diagram here as well as we go along. Yeah. So out of first aid, again, before we go through things in depth, just a quick little overview. Again, we're talking about the 5 phases of myocardial action potential, starting with the rapid upstroke and depolarization as phase 0, and then we have an initial repolarization, and then a plateau, before we have a rapid repolarization, before coming back to a resting potential. And some things to note here that's special about cardiac muscle compared to all the other muscles in our body is that this plateau phase is unique to cardiac muscle, which we'll talk about further later. And cardiac muscle requires calcium-induced calcium release. It needs the calcium influx to induce calcium release from the sarcoplasmic reticulum, which we'll also talk about a little bit later. And again, these gap junctions. This comes up again and again. Very important to know that they have gap junctions and they're electrically coupled. Okay. So we're going to start with phase 0 of our action potential. And like I said before, this is our upstroke and rapid upstroke and depolarization. And what happens here is we have our voltage-gated fast sodium channels opening. So because of that, we have a high sodium conductance. So you can see here, voltage-gated, sodium channels are open, lots of sodium coming in. Again, lots of sodium coming in to the cell, high sodium conductance. And the speed at which the sodium channels, not the sodium channel, the sodium is able to enter the cell will determine the slope of phase zero. So if we're going a little slower, our slope can alter. And some farm attachment here, stimulation of beta-1 receptors. If you have someone taking epinephrine or norepinephrine, can increase the slope and increase conduction velocity. So if we were over here taking those drugs, we'll bring back up the speed and slope of phase zero. So allowing for the heart to pump faster. And this is also responsible, phase zero, for the QRS complex of an EKG. So toss that up there just for visual. This portion, QRS complex, where we're having, again, rapid upstroke and depolarization. And in reference to this picture here, I'm talking about the part of the cardiac cycle that has to do with this blood pumping down through the ventricles. Okay. And again, just to reiterate, I'm not going to go through the cardiac cycle too much, but just wanted to show you when we're looking at a diagram like this, for phase zero, we're talking about this region here. And again, with how the slope is, this is our phase zero. So we have our resting membrane potential until we hit a threshold between our potassium efflux and influx with those rectifying currents, allowing us to reach this very close threshold here. And once we do, our voltage-gated fast sodium channels open, and we have this boom, rapid upstroke, depolarization. And then we have phase one, which is known for slight repolarization or early or initial repolarization. Lots of different ways to mention this here. And what's happening here is our voltage-gated potassium channels are closing. And our voltage-gated potassium channels are beginning to open. So there's a little bit of time delay here before the next phase where potassium is taking over and allowing for a little bit of a repolarization because of our potassium current as our sodium channels slowly start to close. And you can see right here where that is occurring. This diagram doesn't include potassium down here, but just know that that is happening still as our channels get to open more and more and more. Phase two is our plateau phase. Now this one, again, remember, is special to cardiac cells. Skeletal cells don't have these. Here we have a continued depolarization because we're still above this threshold level, which opens voltage-gated calcium channels, known as the L-type channels. And the voltage-gated potassium channels are still open and still doing their thing. So you can see here we got calcium opening, potassium's still open, that's still going on. So, calcium is going in, potassium is going out, so they kind of offset each other, which is why we have this little bit of a plateau. And also note here that this influx of calcium is going to trigger the release of calcium within the sarcoplasmic reticulum within the cell. That can result in cross-bridge cycling and muscle contraction. And this phase is responsible for the ST segment of an EKG. So this guy right here. And just special to note here, because this portion results in muscle contraction and creates this segment, when you think about MIs, if they're STEMI or non-STEMI MIs, the reason you have a change here is because of problems with muscle contraction. If you have dead cells, they're not going to contract. So that's a key finding there. And again, on this diagram, when I'm talking about the ST segment, I'm talking about here, during the period of rapid ejection, when we are contracting our ventricles and everything to get all that blood out to the body. And on this diagram, just wanted to explain again, we have our calcium entering the cell, trying to raise or depolarize further, and then we have our potassium channels that are newly opened, trying to leave the cell and repolarize, and they cancel each other out, and you get this nice little plateau. Okay. Then we have phase 3, which is our actual repolarization phase, instead of phase 1 being that initial drop. This is where we have our major drop. This is when our L-type calcium channels begin closing. So you can see they start losing the amount of calcium that's coming in there. But the rectifying potassium channels are still open and they're still there. So they are going to push this membrane potential all the way down to repolarization. And since they are the only ones being open, since the calcium channels are closing, they win. They don't have that competition that we saw in the plateau phase. And this is responsible for the T wave of an EKG. So you see there our lovely T wave. And just so you can see it on here, there that is. When we are no longer pumping out the blood so quickly, we've lost most of our blood, so our volume's kind of dipping out. That's what we have going on here. And again, just so you see it progress on the diagram, we have our phase 3 right there. And last for these guys, we have phase 4, when we return back to our resting membrane potential. The fast sodium, the L-type calcium, and the rectifying potassium channels close, but our regular potassium channels remain open like they have been the entire time. They no longer have to worry about all this other stuff going on. So we're just back to this regular resting period. There are some leak currents going on that allow, well, potassium is definitely continuing to escape like it normally does. We might have some leakage of sodium and calcium into the cell as well, but not significant enough right now to cause any major changes in here, but later on, of course, you're going to have another action potential occur. And again, on here, when we're talking about resting membrane potential, from everything else past our T wave. And there it is, down there, phase 4, which looks a lot like this phase here before we hit phase 0. Just a continuation. And one more time to quickly review this, because this did have a lot of steps, so I want to make sure we understand it well. We have our regular potassium current leaving the cell before we hit threshold, and we have our action potential beginning at phase 0 with a rapid sodium channel influx. So our sodium conductance is going to be high at phase 0. And then during phase 1, when our sodium channels begin closing, but potassium is still doing its thing, we have a slight repolarization before our calcium channels open up and take over. A little bit of a delay, you can see here, that allows for this to drop before phase 2 takes over. And we have calcium coming in and potassium going out at the same time from these rectifying channels that give you the plateau before calcium loses its momentum. These channels start closing. The potassium is still going for a little bit longer, which allows for phase 3 repolarization. And these channels eventually close, leaving our regular potassium channels to keep doing their thing, unopposed by anything else at phase 4. And yeah, so I was going to move on to the action potential for nodal cells. And before I do, did anyone have any questions about the myocardial action potential?
Good job.
Okay. So now we're talking about our nodal cells. What do I mean by nodal cells? Well, I mean our SA and AV nodes. And what's special about this action potential is that it lacks our fast sodium channels. And this upstroke that we saw previously because of a sodium channel is now mediated by a calcium current instead. And because we don't have these sodium channels, phase 1 and 2 are missing. So we have this weird phase 0, phase 3, phase 4 thing going on, named based off of our previous action potential, but no 1 and 2 without those sodium interactions. And again, when I'm talking about nodal cells, what we're including here are again the SA node, the AV node, and somewhat of the Purkinje fibers have some, again, automaticity action. But we primarily focus on our SA and AV nodes here. And quickly with first aid before I go through it a little more in depth. Again, our pacemaker action potential, we primarily care about our SA and AV nodes. And here we are going through phase 0, 3, and 4. Remember, phase 1 and 2 are absent. And yeah, so let's get to it. So a little bit about the action potential for nodal cells. Nodal cells are, like I said before, specialized to be automatic. So they have spontaneous depolarization at rest, and this is what's referred to as a pacemaker potential. So the key players here are our inward calcium current, an inward sodium current, and an outward potassium current. So our inward calcium current here is primarily related to our T-type calcium channels instead of the L-type. And these are different because the T-type open at a more negative membrane potential, at -70 instead of what we saw before, which was way higher, somewhere around there. Our inward sodium current comes into play. It's referred to as the funny current here because, like I mentioned before, we don't really have opening of fast sodium channels. So it might be a little confusing to see an inward sodium current here, but again, this is referred to as the funny current, and it comes into play because the channel that's involved is called the, let's write that out, sort of, hyperpolarization activated cyclic nucleotide gated channel, or HCN, because we don't want to say that out loud too many times. It's long, too hard to remember. HCN channel, much easier. This is a non-selective monovalent cation channel. So it conducts for both sodium and potassium. So you have a mixed current of sodium as well as potassium coming into the cell. Now that's weird because potassium is coming in. A little different than what we've seen before. Opening of these channels evokes a sodium-mediated depolarization, and they open when the membrane repolarizes to a negative membrane potential and close when the action potential depolarizes. So these guys work down here. And they are important for the automaticity portion of these cells. And these are also important for determining the heart rate, which I'll explain further about as we go through this cycle. And last we have our outward potassium current, that's our friendly outward potassium current that we always see sticking around as the cell goes into, as the cell repolarizes, we rely less on this potassium, so you have a reduced current as we're coming back down to where it used to be, which helps produce the potential for the next action potential to occur. Clear that there. And just so you can see it here before I explain it again, when I'm talking about the funny current, I'm talking about this guy right here. And I will explain here. Okay, so I'm going to start with phase 4, like we saw in the first aid diagram earlier. And this is where we have our resting membrane potential. In phase 4, we have a slow, spontaneous diastolic depolarization. So we have a very slow thing going on here. Slowly depolarizing. And this is where we have our funny current, we'll label that with an F, going on, where we have both sodium and potassium coming into the cell, which again will determine the speed at which the rest of this action potential will occur. And again, that accounts for the heart rate. Do I have that in there? There it is. Our phase 4. And after which we have phase 0, mediated by the opening of our calcium channels here. So our calcium channels are opening up. Add that in here. So once we have hit this threshold, calcium channels open up, and we have this much steeper upslope that we can refer to as phase 0. The slope of this phase 0 is not as steep like it is in the myocyte action potential that we saw earlier, where we saw that rapid upstroke for phase 0. And this is because of that slowed conduction in our AV node. We want to give time for those ventricles to fill up, so we got to slow down a little bit, not go quite as fast as the rest of our muscle cells. And last, we have phase 3, which is our repolarization phase, as you can see here. And in phase 3, our calcium channels become inactivated, and our potassium channels become activated. And these are different than that funny channel because that was an inward potassium channel along with sodium. These are just regular rectifying potassium channels leaving the cell. And this is what returns us back down to a normal level. And also allows us to have the potential to do this all over again. Okay, so any questions about any of that before I have questions for you? Alrighty. First question. Physiologists conducting research on the electrical properties of the heart measure action potential conduction velocity at 4 different points within normal cardiac tissue. The results, expressed in terms of speed of conduction in meters per second, are as follows. 0.1, 0.05, 0.2, 0.3, 0.3, 1.1, 0.4, 2.2, from the following list of locations, which most likely correspond to the order of points 1, 2, 3, and 4, in that order. So just to note here, because that first sentence was a little wordy, we're looking at action potential conduction velocity. Okay. Well, I'll give you a little hint here. So we have point 1, 2, 3, and 4. So which one is fastest? Which direction are we going?
We're going fast to slow.
Like this, so if something's moving at 0.05 meters per second, this is actually going to be slow compared to something moving 2.2 meters per second. So we're going from slow to fast. So we want to know which has the slowest, again, conduction velocity, and which has the fastest, and everything in between. So
AV node is slowest. Purkinje is fastest. So C.
Yeah.
C is correct. So again, I'm pulling this slide from earlier when we were talking about speed of conduction, just like Yash said, Purkinje's are fastest. AV node is the slowest. Purkinje is fastest because we want to make sure that that potential is being conducted super quickly throughout all these cells in our ventricles so they can conduct together, while our AV node is concerned about ventricular filling, so it wants to slow it down. And then we have our atria and ventricles in the middle. Our atria are going to pump a little faster, well, are going to conduct a little faster than our ventricles, one, because of size, and two, because we want to quickly fill as well. Any questions about this question?
Nope.
Okay. And our last question. Special electrodes are used to detect the change in membrane potential of a specific type of cardiac cell. These changes are recorded on the graph below. The deflection indicated by the arrow is most likely caused by movement of which of the following ions? So, when we see this graph, what kind of action potential is this? Is it the myocytes or the nodal cells?
Nodals.
Yeah, so the nodal cells, we're talking about our SA and AV nodes. Do we know what phase of this membrane potential slope that we are pointing to?
0.
Right, this is phase 0. So what is causing phase 0 of the nodal action potential? What is making that deflection occur?
C.
Sodium. Calcium.
It's going to be calcium. Because, let's just see if I have the picture here. What's happening in phase 0 is primarily calcium. We have our opening of our voltage-gated calcium channels. We do not have our fast sodium channels. The only time we have sodium in our pacemaker action potential is with our funny current. And that's sodium with potassium. It's not by itself. We don't have these guys at all. Make sense?
Yep.
Any other questions about these guys? So when we talk about something causing a deflection from sodium, we're talking about phase 0 of our myocyte vaccine. Right. And when we talk about potassium by itself, do you know what we're talking about?
Wouldn't that be phase 3 of the myocyte?
Yes.
Yeah.
So it's going to be phase 3 of the myocyte. It's also going to be phase 3 of our nodal cells. In here. That's potassium too.
True.
So phase 3 for both of them. Calcium we just talked about here. How
Could you
about
say potassium for phase 4 of the myocyte too? Because it is permeable for potassium channel.
that is true. I would say that for myocyte also. Chloride isn't even relevant in our action potentials here, so we're not going to talk about that for our cardiac cells. How about sodium and potassium together? Where do we
Phase
see
4 of the nodal cells.
That is true. We do see them in phase 4 of our nodal cells for high funny currents. There's a letter N there.
Phase 1 of the myocyte.
Perfect. Phase 1 of the myocytes, when our sodium channels slowly start to close, but potassium is still open. And then last we have calcium and potassium. Where do we see that?
That's a plateau phase.
Yes. Phase 2, something special to cardiac cells in our plateau phase for myocytes. Awesome. And that's all I have for you today.